Thank you for that introduction. And thank you for having me here at the Center for Latin American Studies. I was just mentioning that I'm extremely grateful to the Center for Latin American Studies for helping my students travel to Latin America. I've had students in the Dominican Republic over the summer, and Mexico and Brazil. So I'm really, truly grateful and honored to be here. So today I'll be talking about 5 key points. The first is describing some of what we know about the nutrition transition in Latin America. And what this is a transition from dealing with problems of undernutrition to problems of overnutrition, and in many cases, dealing with both problems simultaneously. I'll then talk about some work that I've done in collaboration with Sylvia Gendelman on cultural perceptions of body size in Mexico. I'll continue by talking about co-occurring malnutrition and obesity in Mexico and Peru. And I'll finish with a discussion of some work I've done in Mexico on a conditional cash transfer program and its effects on nutrition-related outcomes. I'm sure all of you could recognize severe malnutrition. These are children who are starving, who are below -3 or -4 standard deviations in terms of weight or height for age Z-score. But you might not be able to recognize stunted growth, which is considered to be invisible malnutrition. These girls, for example, are from slums in Kathmandu. They're both from the same school, from the same neighborhood, and they have the same birthday. They're both around 9 years old. But the girl on the right has a normal height for age, about 0 in terms of a height for age Z-score, and the girl on the left has about 4 standard deviations below in terms of her height for age. So this is considered invisible because this girl is going to school, she's wearing the uniform, the school uniform. You can see that she's playing with her friends and participating in classes. But what you might not know is that stunting, in her case, has long-term consequences. She's experiencing reduced cognitive development, poor motor skills, lower school achievement. She might be more likely to be quiet, reserved, withdrawn, have difficulty making decisions, and then has reduced labor force participation later in her life. There's even a increased risk of cardiovascular diseases for children who are stunted. What we also know is that stunting is a serious problem in low and middle income countries. Over 40% of children in developing countries are stunted. You'll see Latin America has one of the lower prevalences of stunting when compared with other countries in the world, but there are pockets of stunting. For example, in Guatemala, prevalence of stunting is 50%. In areas of Mexico, for example, by the border near Chiapas, the prevalence of stunting is about 30%. So in spite of the fact that the average in Latin America is about 12 or 13% of children who are stunted, there are still areas of high stunting prevalence, particularly in remote populations and indigenous populations and in the most vulnerable populations. What we also know is happening in countries, in low and middle income countries, is the increased prevalence of obesity and nutrition-related chronic disease. We have this co-occurrence, the global paradox of obesity and malnutrition. I call this the risk transition. This is called the nutrition transition. It follows the demographic transition. And what this means is that health risks are shifting from traditional risks, such as inadequate nutrition or unsafe water or unsafe sanitation, to these modern risks of overweight and obesity. So these risks and these profiles and these trajectories can take different contexts in different countries. But on average, this is a trend. And what are the reasons that we have this transition? Well, you can see here is a conceptual framework of how you move from the left of rural traditional diets that are low fat, low sugar, high fiber, that may represent inadequate energy or nutrient intake, and as a consequence, undernutrition and increase of risk of infection. As the nutrition transition occurs, you may move through a period of adequate and prudent nutrition, which would represent optimal nutrition status, lower risk of chronic and infectious disease. But then you move on to an affluent, modern Western diet of high fat, high sugar, and a diverse, varied diet, which also could be high in animal protein. And as a consequence, this might be nutritionally adequate to avoid the problems of malnutrition, but would then result in obesity, coronary heart disease, diabetes, hypertension, and stroke, putting these populations at great risk. What I'm going to show you now is this prevalence of obesity. This is a map prepared by Barry Popkin at University of North Carolina. And what you're seeing here is increasing prevalence of obesity. Now, this is among women. The patterns of overweight and obesity globally for these nationally representative samples. You see populations with 10% prevalence, 10 to 20% prevalence, 21 to 30% prevalence, increasing to 31 to 40%, then 41 to 50%, and over 51%. And you can see much of Latin America is pink and red, indicating an increased risk of obesity. Here, thank you. I can move out of the way. I don't want you to miss this slide. You can see that the Latin America here really has a very high prevalence of overweight and obesity, and this is combined with a high prevalence of malnutrition and stunting. So these conditions are co-occurring, and what you can see here, again, these are slightly updated numbers, but you can see that some countries, particularly in Latin America, would have a high prevalence for men and women of overweight. Brazil up here at 50 to 60%, Mexico very high at 60%, and Argentina here 60 to 70% prevalence of overweight and obesity. So when you look, for example, at the disease burden attributable to 19 different risk factors, you can see this is a list ranging from unsafe sex to high cholesterol to illicit drug use. Out of 19 risk factors, you can see risk factors that relate to undernutrition, such as underweight, vitamin A deficiency, iron deficiency, low fruit and vegetable intake, zinc deficiency. And then you also, on the same map graph, see overweight and obesity, high blood glucose, and high blood pressure. So you can see this could be a real conundrum in terms of thinking about policy and policy objectives in terms of dealing with both of these problems simultaneously. Yes? This is global. Are there any questions at this point? So the last overview slide that I'm going to provide you before talking about my own research is to show you that sometimes these conditions, not only are they coexisting in the same country, can coexist in the same household. For example, what you see here are graphs that are showing you the prevalence of maternal undernutrition against prevalence of maternal overweight. And on the right, which is the one I want you to focus on, is the prevalence of child underweight and the prevalence of maternal overweight. Now these numbers are different than the numbers I showed you about stunting, because this is underweight, which is a different way of looking at malnutrition than stunting. This is looking at weight for age Z-score. But just to point out an example, let's just take Guatemala for the example, where you would have, in this case, 20% of children who are underweight also existing with a 45% of mothers who are overweight. So this is telling you that these conditions are coexisting, and often you'll have within the same household an overweight mother and an underweight child. So what I'm going to tell you about now is a small study that I conducted with Sylvia Gendelman on the cultural perceptions of body mass. We recruited a population of children 4 to 6 years old and their mothers from San Francisco General Hospital of Mexican origin, and then also recruited a sample in Mexico. And we tried to focus on sending communities in Mexico. And we asked mothers, if you could put your child on this scale, ranging from 1 to a 7, these are based on the Stunkard scales of body perception, where would you put your child in terms of their actual body weight? And where would you put your child in terms of ideal body weight? And what we found, again, this is comparing Mexican mothers with Mexican American mothers of 4 to 6 year old children. And what we found was that mothers in Mexico preferred a significantly larger ideal body size. So this is about a 4.3 compared with about a 3.86. And of the mothers who had a child who was actually overweight, the mothers in California exhibited the sense that they were dissatisfied with their child's weight. So 82% of mothers who had an overweight child said they were dissatisfied with their child's weight, whereas 29% of mothers in Mexico. And when we probed these findings in qualitative interviews, we found comments like this: a bigger baby is a better baby. Chubby babies are considered to be healthy, cute, and growing well. Another mother said, my child was born preterm. He was so small and thin that we thought he would die. And now he is heavy, but he is also big. A third mother said, babies outgrow their fat. Diets are not good for children's growth and development. And another mother said, one day I felt really bad because someone told me that my daughter was thin because I did not feed her enough. So we found these comments to be really illustrative, that in a context where you have a distinct memory of malnutrition yourself, or a distinct perception of against malnutrition, that there's a sense that you want to have a chubby baby or a bigger baby. I have 4 kids. One's a 1-year-old. They range from 1 to 9. So the 1-year-old, I know that when she goes out and she has like many chins and mini rolls of fat around her wrists, people say, oh, she's so cute and so chubby. And that's something that people really desire in babies. And so it's hard to then say and come with a cultural message to say, well, that's, we have to think about dieting or weight loss, or that's not a good thing. So what we looked in the literature and found that there's this perception up to a certain age that chubby is a good thing and considered positively, but then there's a switch that happens, which is that towards adolescence, then there's less of a positive acceptance about the weight. But at that point, the children are on such a trajectory of weight gain that it's very hard at that point to do anything about it. So this really is a conundrum. If you're talking about a cultural situation where there's a lot of acceptance and reverence for a particular body type, that's not necessarily associated with health in the long run. So that's something I'd love to talk about as a group, because I find it a really complex and difficult issue to think about. So what I'll also talk about now is work in Mexico with the conditional cash transfer program. And I'll start by giving you a little background just about Mexico. I'm sure many of you are familiar with the fact that Mexico is situated as a middle-income country with a high literacy rate, and also high indigenous population, and a high prevalence of stunting. So 16% of children are stunted on average, but as I mentioned, this ranges from 5% in the northern region to up to 30% when you get closer to Guatemala. The other thing that we found in Mexico, and this is also what I've been finding in analyzing data from Peru, is that 10% of indigenous children are stunted and overweight. So I'm going to say that again. 1 in 10 indigenous children experience growth retardation secondary to poor nutrition, and it's also obese or overweight, secondary to too much nutrition. So how does this happen? We don't know. We do know that the timeline and trajectory for stunting occurs about before the age of 2. So it's possible that one hypothesis is that you are on a trajectory for being stunted, and then by the age of 2 or 3, you can't do much about stunting, with the exception of a few moments of opportunity during puberty or later in life, when there's rapid growth, rapid linear growth, that it's possible that a child with a smaller frame is then just having more opportunity to gain weight in an environment where there's an abundant number of calories. The other possibility is that children who are poor are just vulnerable to whatever nutritional insult it comes their way. So they're vulnerable to being stunted and also to being obese, because those things are associated with being poor. So for example, in our study in Mexico, where we showed that 10% of indigenous kids were obese and stunted, we found that the ones who were the most vulnerable for that double condition of both types of poor nutrition, those were the ones who were the poorest, who were the most vulnerable, who were the most marginalized societally. And this is also what we're finding in Peru. I'm looking at some data now that's longitudinal, so I'm able to try and see what the time course is. Is the stunting coming first? Is the obesity coming first? And is it possible to slip in and out of these conditions? So the interesting thing there is to start with a child who's stunted and then see what are the risks of being obese over and above being stunted in that context. So this is an area of active investigation, and I think represents to me the crux of the problem in the nutrition transition, which is that you're being exposed to both of these risks simultaneously. And we have no idea, because this is such a new phenomenon, we have no idea down in the long term what the consequences are for a child who has both conditions, because it's such a new phenomenon that we don't know what the consequences will be 50, 60 years down the road. So I'm going to tell you a little now about the Mexican conditional cash transfer program. which I've been working on with a team to evaluate for the past 10, 15 years. And I'll go through how that works, how the program works, and then what its effects have been on nutrition-related conditions in children and adults. And I'm going to be consolidating a lot of information. So I really want you to ask questions if you have them. And we can also talk about them the break. This represents a large amount of work. I guess I just mean that I don't want to sound like I'm breezing through it. So I'm very happy to delve into the details for anyone who's interested. Please just interrupt me. Any questions at this point, up to this point? Yes?
Just for reference,
Sure.
what happens to the stunting rates and
Less than 2%. That's what statistically you would expect, because it has to do with a distribution, a reference distribution. So you would expect it to be less than 2%, and that's what the normal population is. Now, yes, Bobby. Did that answer your question?
Yeah.
Okay.
With respect to co-occurrence,
Yes.
it's 10% of indigenous children as related to population or Mexico-wide. What's the?
Oh, in the non-indigenous population, it was 5%. So it was a double the prevalence. And we're finding, same in Peru, that the prevalence of co-occurrence of stunting and obesity in indigenous kids in Peru at the age of 5 or 6 is 20%. And it's about double what it is in the population. That's not published yet. I'm in the middle of analyzing this data. Yeah, question?
But if you look at income, is it still higher just because they're indigenous, or is there a correlation there with having lower income, and that's why it's double then?
Oh, are you saying, is it just the income explaining it? Yeah, so if you put them in a model together, and indigenous is a significant predictor, but wealth is also a significant predictor. So this is just looking at simple prevalence, but those results I told you about, those were regressions. It was a multinomial logit where we took 4 groups, stunted and not obese, obese and not stunted, co-occurrence of stunting and obese, and then a healthy, non-obese, non-stunted population. And so in that multinomial logit is when we can look at each of those different groups compared against each other and can look at the role of wealth and the role of indigenous ethnicity. Now there seems to be an independent effect of both of those, but there doesn't seem to be an interaction term. So I guess the wealth is operating the same regardless of indigenous versus non-indigenous ethnicity. Does that answer your question? Any other questions? Did you want to ask that follow-up question?
I know nothing about biology or something. Does it require not enough calories, or if you had a high-calorie, low-nutrient diet, could that also cause it?
Both of those situations can cause stunting, both low nutrient dense and low number of calories. Originally, it was thought to just be related to protein deficiency, but it turns out that it's not specifically about any one nutrient. There are nutrients, though, for example, micronutrients like zinc, which can directly cause stunting because of the way that they interact, because of the crucial role that they play in the growth process. But I would say that most other micronutrients aren't so specifically implicated. It has more to do with just a general poverty and general deficiency. And as a matter of fact, this is the reason that stunting is used as a proxy measure for poverty in studies like the DHS and other analyses. Yes, Karen?
And was there any particular nutritional profile for the mothers of the children who were both stunted and overweight?
That's an interesting question. We did not look beyond the household variables in terms of mother's education was one that we looked at, and mother's education was higher. With lower mother's education, you had a higher risk of being stunted and a higher risk of being obese. And what we're finding in Peru is that if you compare across all stunted children and just take those ones who also are obese, the biggest risk factor for them is having a mother who's also obese. So it has to do with being poor and vulnerable, and then also the mother being obese for whatever reason, possibly genetic, possibly food choices, possibly what food is available. There are a whole host of reasons but we did not have that information in the Mexico study. That we're just exploring in Peru. Any other questions?
Is the big difference between urban and rural?
This was only for rural. I don't know what the prevalence is in urban. In the Peru study, it's a combined sample of rural and urban. We're not seeing differences. I was surprised because I thought there would be differences, but the Mexico study is just rural. What would you hypothesize?
You know, that in rural could be less after adjusting my everything.
Yeah. That's why I thought that this might actually be an underestimate of what exists at the national level, because the rural population might be lower, because my hypothesis would also be that the rural was lower. So how do cash transfer programs work? These are programs, and again, Brazil was the first cash transfer program, and Mexico followed closely thereafter in 1997. So these are programs that, instead of taking a targeted approach, like we're going to distribute vitamin A, or we're going to really focus on keeping girls in school, or we're going to focus on getting children to health checkups. These are programs that say, look, the biggest problem here is poverty. So let's address poverty, and then these other problems will resolve themselves. So when economists and public health people came together to come up with a solution here, the solution was, look, let's give people money that they can spend however they want. They can solve whatever constraint they have in the short run. For example, they can buy a refrigerator if they need it, or they can buy their child shoes, or they can buy food, or they could buy cigarettes. There are no constraints on how you spend the money. The constraints come with how you get the money. So as long as you participate in the sequence of requirements, then you are eligible to receive what turns into 25 to 30% increase in your income. So it's quite substantial. Mexico's program is large, 25 to 30% increase compared with, for example, Ecuador's program, which I also evaluated, is only a 7% increase in income. So there's a big difference across cash transfer programs in terms of how much cash they're providing. The goal here is to improve outcomes, growth, health, school achievement, and through these program requirements, the goal is to try and make sure that people comply with what public health community has determined is important for optimal development. For example, checkups for prenatal care, growth monitoring, immunizations, management of acute diarrhea, receiving treatment for parasites. So these are examples of what you would receive at a checkup. Pregnant and lactating women also receive checkups and nutrition supplementation, and adults receive only 1 or 2 checkups a year, and they also have a form of a gathering once a month, in which they can talk about nutrition or discipline or domestic violence. It can range any number of things that would be covered during that conversation that the adults would receive. So the evaluation that I'm going to tell you about began in 1997 when communities were randomized to early or late intervention. And I'm going to show you data from this survey here, nutrition-related data. There was lots of other information covered in each of these surveys, which I can happy to answer questions about, but today I'm really focusing on the nutrition. So what I'm going to show you are 2 different types of analyses. One is comparing kids in this group and in this group, and one is looking at just the cash transfer itself. So what you see here is a treatment effect with covariates on a range of outcomes relating to child outcomes. Height for age, for example, body mass index, which is a measure of obesity, overweight, verbal performance, cognitive performance, and behavior problems. And what you can see here is that when you're simply comparing the early treatment versus the late treatment, the only difference between these 2 groups in terms of participating in the cash transfer program or not is in behavior problems. There wasn't an effect on height for age, on body mass index, on verbal performance or cognitive performance. Now, what I'm going to mention to you now is that the program was designed to run for 3 years between the treatment and the control. So what happened was that 18 months into it, the control group got rolled into the program. So there was only 18 months difference between the early and late. And thinking just conceptually from a child development point of view, it might not be sufficient period of time to see the results that we were looking for and that we would have hypothesized would have changed. So what we did then, and this was with my colleague and co-author Paul Gertler at the Haas School of Business, we then tried to figure out a way to look just at the cash transfer component of this framework to say, what could we say about the cash transfer component and how it child development outcomes. And I'm also going to show you then a few results relating to the adults. So this transfer amount is calculated as a basic stipend and then also an educational stipend. So the basic stipend was kind of a unit amount per household that was designed to be spent on nutrition. And the educational stipend depends on age, sex, and grade of the child. So the big goal of the program was to keep girls in school, in particular to keep them into high school. So the stipend was biggest for girls who were going into high school, and then slightly smaller for girls in middle school, and then smaller for boys in each of those stages. So it's a complicated equation, but really had very clear policy reasons for developing that formula for how to determine the amount of cash in the transfer. In terms of thinking about this cash transfer, we then were able to show, this is again looking just at the cash transfer and taking just children who had been enrolled in the program their entire lives, and found the increased effect of increased cash associated with increased height for age, a decreased prevalence of stunting, a decreased prevalence of overweight, and increased improvements in gross motor development, long-term memory, and language. So at 3 to 5 years, the cash transfer program, just the cash, was associated with improvements across the board, including in the direction that we had wanted in terms of stunting, and reducing overweight. So we were thrilled to be able to have these findings, because it suggested that the money coming to the household was solving both of these problems that seemed to be unsolvable in terms of thinking about the nutrition transition and the crux here. We were disappointed then by 8 to 10 years to find that the height for age was had still improved with association. So there was still an association between cash received and height for age in 8 to 10 years old. Again, this is a longitudinal study. We're following these children and looking at cumulative cash transfer at this time point. But by this age, the effect on body mass index had become insignificant. The effects on verbal performance, cognitive performance, and behavior problems were still significant. So these suggest that the effects on stunting were early and later, but the effects on obesity were not maintained. So to give you a summary, I realize this is a lot of information to process, but the summary of the program effect, so again, this is a program effect of program early versus program late. We found better child behavior, but there was no effect on cognition, main effect on cognition, language, BMI, or height for age. There was a greater height in children of moms with no education, suggesting that the program was targeting children. The program was doing its best work for children who are the most vulnerable. And then in summary, the cash effect showed that there was effect of cash alone, controlling for program participation, in improving height for age, improving cognitive and language function tests, and in decreasing BMI, but only at age 3 to 5. So now I'm going to tell you, this is the good news part of this story, that the program, through its cash transfer and its checkups, did have a lot of positive effects on children. And now I'm going to tell you some of the bad news part of this story, which is the effects on adults the picture is not as rosy. What we found in adults was that a doubling of cash transfers to adults was actually associated with increased BMI, increased systolic blood pressure, and increased diastolic blood pressure. These are beta coefficients, so you're looking for a coefficient that's over 0. I'm going to now show you odds ratios. I'm not going to get bogged down in these numbers because I really want to have time to talk about the implications of these findings. But we see that when you look just at the cutoffs of overweight, obesity, and these now are odds ratios, so you're looking for a value over 1, not over 0, over 1. You can see this increased probability of being overweight, increased probability of being obese, and increased probability of being morbidly obese and having hypertension. So what is this telling us? Well, what it's telling us is that there were positive effects of the program in terms of lowering hypertension and obesity of the program itself. But when you look at the cash, and again, I want to remind you that the cash did have positive effects on child development. When you look at the cash effect on parents of the same children, these parents are showing an increase in BMI, an increase in obesity, and an increase in hypertension. So at the same time, this cash that's coming into a household is improving height for age and improving cognition and improving behavior in children. For the adults, it's increasing hypertension, increasing diabetes, and increasing the risk for obesity. What's going on? How can this happen, and what is the explanation? I can tell you that my best guess is that there are some material consequences of the program participation and the extra money in the household. So we do have these consequences of the program, the requirements, we would say, the conditionalities, are associated with getting regular medical care, with getting regular education sessions, and for the potential purchase of assets such as cows and goats. These are all explanations for why the program could be affecting children in a positive way. But we also find that having more resources in this context is associated with increased alcohol purchase and consumption and soft drinks in adults. And this could be a path where you would have that could lead us directly to obesity, because we know that soda consumption is so directly related to obesity. We also have the psychological consequences of program participation. We know that there's lower salivary cortisol concentrations, for example. We know that there's lower depression scores in the moms. These, to me, are a better explanation of why you would see positive benefits for the children. But it still doesn't explain what could be going on for the parents. So in terms of just summarizing, we have these long-term effects of the program on children, so 10-year effects on children, showing reduced behavior problems and improved growth in children of moms with low education. But we also see that the cash transfer component is really beneficial for children. We're seeing improvements in height, improvements in cognition and language and behavior. But these cash transfers may not be good for all family members, because the cash is associated with worse outcomes in adults. And I would also mention that in the last couple of years, other cash transfer programs have found similar findings. These results were really hard to get published when I first tried to publish them, because people didn't want to hear such bad news about cash transfers. As a matter of fact, I won't even tell you that whole story. But what I want to say is I feel vindicated, not vindicated, but in the last several years, several other cash transfer programs, for example, in Colombia, have shown, and possibly Brazil, have shown that there are effects of cash transfer programs negatively on parents, because the cash coming into the household is then associated with increased consumption of unhealthy foods and then the consequent obesity. So a question then is, if the program's having the effect that it should have on children, does the program need to be adjusted? Is this really a problem? If you're weighing child health versus adult health, this is the paradox for policymakers that I highlighted in the title of today's talk, which is, how do you grapple with this question? Which is, how are you prioritizing child health and adult health? And in a context where there may be cultural barriers or cultural issues with even identifying obesity or hypertension or diabetes as a problem. So this is the question of whether the cash transfer should be reconsidered or reoriented. For example, in the US, we have the WIC program, which is a type of cash transfer program, but it is focused, it only allows you to buy healthy foods. And certainly with our food stamp program, there are requirements that you can't buy pre-prepared foods, you certainly can't buy alcohol. So there's many more requirements that we have made constraints. Then of course, the issue with the constraints is that you need to be in a situation to enforce those constraints. So in terms of conclusions from today, I would say some highlights would be that this nutrition transition, which is what we're calling again this transition from under to overnutrition, is occurring throughout Latin America with this simultaneously high prevalence of undernutrition and obesity. I would say poverty is a root cause of both of these conditions, and policymakers are really challenged in dealing with these conditions simultaneously. I would say also that cash transfer programs have been moderately successful. I say this based on a recent review of the literature in terms of the effects of cash transfer programs on child outcomes. They've been moderately successful at dealing with malnutrition, but I have not seen success in the same with cash transfer programs in terms of thinking about obesity. And none of this work would have happened without the collaboration of a huge list of co-authors and research assistants and funding. So I would take a moment to acknowledge the long list of supporters and collaborators and co-authors, and then to say thank you, and I hope we can have a conversation and discussion after this. Thanks very much.
Yeah, so we'd like to open it up for questions now. Is anyone have a question?
Yeah, I really got lost in one detail in the methodology. How can be estimated the effect of the cash transfer independent from the program method?
Good question. So the way this worked was that we took the randomized, so the households were randomized into early or late participation. So there's an 18-month difference, and that was a random assignment. So whether or not how much cash you receive, it's an interaction between when you were randomized, early versus late, and also what your family structure is. So in the models, we control for baseline household demographics and whether or not you were randomized early or late, and that's what's telling us the effect of the program, the 18 months difference of the program. And then we also look at cumulative cash transferred. We have reported cash, and then we also have administrative data to tell us how much cash was actually transferred.
So that sounds like you are assuming that a change, for example, of $100 from 800 to 900, if I understand, is perhaps the same as a $100 to $200. If you are manipulating total cash transfer.
We're looking at cash as the predictor variable. And yeah. And we're controlling for the baseline demographics. So are you saying that we're looking at cash as a linear variable and not a nonlinear variable?
You're looking because at the effect of cash transfer as a linear effect in the outcomes, and it might not be true.
It's not linear, and we absolutely know that because there are jumps when you go to middle school and jumps when you go into high school. So we're definitely allowing it to vary non-linearly.
So when you try to estimate the program transfer, unless you have someone in the program receiving the program and not receiving at all cash, they have some income that you cannot isolate.
Yes, I'll tell you that there's a lot of controversy about this question, about our estimation strategies, and the paper both of these papers were published in The Lancet, and then we had an opportunity to also to provide additional information on an instrumental variable analysis that's when we brought in the administrative data to say what cash was actually transferred, because part of the concern is that there's something about a family that complies, for example, that is different from a family that doesn't comply, so that we were able to completely replicate our findings using an instrumental variable analysis in which we use potential transfer and not just actual transfer. I can show you the paper and go through if you want. Okay. Did you have a question? Yeah.
So do you think that the money that people receive through a cash transfer is used in the same way as the money that they use from other sources?
That's a great question, and I don't know. We do know that this was a paper that Paul did with a former student, Mark Rubio, which was, they're the ones who showed the investments in assets. For example, they showed that a large percentage of the money, the oportunidades money, went into livestock and other potential assets. And that suggests that the program is more sustainable than people had given it credit for, because it was allowed the family to then sustainably get themselves out of poverty. But in terms of your question is really relevant, whether or not people are thinking of that money differently. I'll tell you a few things. One is that the money is given to the female head of household, and she is kind of encouraged to spend it on her children or to spend it on nutritious or better food. So it is designed to be perceived as a different pot of money. But whether that just ends up replacing money that would have otherwise been used for that, and then that money gets set aside and used for alcohol or soda or some other purchase, I don't know.
And I was asking this because, you're showing that increased cash transfer is leading to other negative health impacts in adults. I don't think anyone's going to argue that should be income, right?
Right.
So if not, I think the policy question, which I think you alluded to that as well when you mentioned the examples of weak It's not so much to reduce the amount.
Oh, no, not at all. Absolutely not at all.
But to maybe change how.
Right, or to say, look, this money really needs to be focused on children, or the goal of the program is to focus on children. But the question of whether money then flows into the household, and even if that money is then spent on the children, it frees up other money that you might have. So it's complicated, and I think that's why in this country we have ended up with more restricted programs that specifically say what you can and can't spend money on. And WIC has gone so far as to say, this voucher is good for orange juice or milk or cereal, not even cash in any form. So yeah, I don't know. I don't think the program's getting to that point at all, where it would look like a WIC program. But I do think they're trying to do more education. Yeah.
Moving that right. It's Mexico. The Mexican government has the CONSA, which has 20,000 stores in rural communities.
Yes.
So it has the infrastructure to make that happen.
I don't know.
Have you had?
I haven't had that conversation. I have not. My policy communications are really much more around early child development. So I'm in the process. What I really focus on is early child development. So what I'm in the process of doing now is helping evaluate the parenting program overlay on Oportunidades, which was Educación Inicial, CONAFE. So so that's where my real passion is saying, well, we didn't actually see as big effects big enough to be satisfying in terms of the cognitive development. And maybe just giving cash and information about health checkups and nutrition isn't really enough to improve language and cognition in the very vulnerable population, in particular the indigenous. So the study that we're doing now is really focused on indigenous populations and really saying, what can we do to support parents to improve and to have group learning sessions and group parenting support and encourage enrollment in preschool and getting prepared for primary school. So yeah, I've had those policy conversations and not the ones about the nutrition, but I agree with you, it's a good idea. Victor.
Finding that you showed that one of the best predictors for child development was the expectation of the mother, like after macronutrients. What about exploring adding a component about these powers?
Well, I was just talking with a collaborator at INSP in Mexico about looking at really trying to focus on maternal affect and maternal depression, because one thing we found is that prevalence of depressive symptoms is so high. It's over 50% in rural areas, and this is using a completely adapted, culturally appropriate test of depressive symptoms. So one thing we're talking about is potentially really just focusing on maternal affect and reducing depressive symptoms as a path to then improving child's nutrition, because there are some interesting findings, for example, from Pakistan, that showing that just addressing depression alone can improve parasitic infection and also improve growth. So it's possible that you can get there without going through the nutrition pathway at all. That's a good idea. Did you have a question? Yeah?
Well,
Karen?
yeah, I did read that Mexico now has the highest per capita rate of soda consumption.
Yes.
And I'm wondering whether this program has...
It's true, and the highest prevalence of diabetes in the world.
Yeah, so I'm wondering whether this program has been a boon to the soda companies, if the parents can use the money however they are, and I'm wondering whether data has been collected on what percentage of the money has been spent on soda and junk food. And I'm wondering whether they're going to be advocating against restricting the use of those funds on just healthy food. And I'm wondering with the new soda tax and junk food tax, whether there's going to be any change in the results here.
It's a really interesting question. And you're saying that you think that soda companies would actually be against having any restrictions, just like they are.
If they're making a lot of money.
If they're making a lot of money.
On this, but I think it would be helpful to see what percentage of families' extra money through this program is being spent.
Yes, it's a great question. The person I think who's doing that work now is Juan Rivera at INSP. He's looking at, and he was also part of the reason that the soda tax passed in terms of looking at the income elasticity and purchasing of soda. So yeah, I can connect you with him if you're interested. I think it's a great question. Yeah.
And what about available sources of clean water so that there isn't a need to drink bottled carbonated drinks?
Right, it's a great question.
Is that an issue at all? I know I can gather that's been an issue.
Yes, and I think that you're absolutely right that in a sense you're making the argument that it's a perfectly rational decision to consume soda if you're worried about the quality of water. And it's right. So I mean, again, this comes down to a question where you're looking at parents making rational decisions. They're in their own mind and their own world. This is a rational decision. You're more worried about your child getting diarrhea and than you are about them becoming obese, which may be a sign that of that child being healthy or that child being well fed and well nourished. So I think you're absolutely right. This is why I hesitate to turn this into anything about parenting or parenting decisions, because again, parents make their best decisions given what their world is and what their life is, and so it could be a perfectly rational decision that's causing them to buy soda. It could also be that there's soda available and not water, and this is also an industry-driven decision, which is made for them because they don't have the option of buying water or even getting fresh water. That's a great point. Yeah.
I would like to know whether the drugs were working.
Mm-hmm.
And as I haven't seen any ski obese overweight.
Yeah.
Some of them have a star sound.
Yes.
Not overweight, and have you worked with them?
Also in Mexico.
Yes. So what is your perception about that?
Yeah, so I'm wondering, are you, I'm wondering if we can compare what regions we're looking at. So in terms of the population that I showed you where we showed that 10% of the children were overweight and stunted, those were from 7 Mexican states and the indigenous populations within those states. For this study that we're doing, where we're looking at Educación Inicial and the CONAFE project, that's where we're just looking at Chiapas, Puebla, and Oaxaca. And I have the list of all the different groups, and I haven't calculated the prevalence in those populations of obesity in those populations. But I think, like I said, if it's consistent with what the prevalence was when we did this 5 or 6 years ago, it's about 20%. So I'm wondering if maybe we're using different scales or what kind of cutoffs you're using. Or are you talking about visual perception? Yeah, I mean, it's possible that due to the stature, or you're assuming that they're younger, I don't know. We're using the WHO recommended cutoffs for obesity and stunting, and those standards were developed in 6 different countries. One was the U.S., but the rest of the countries one was Brazil, one was, I forget what the other 4 countries were, but one was India. So there were regions all around the world representing different racial and ethnic groups, finding that all racial and ethnic groups in each of those populations have the same potential in terms of linear growth that across the world. So that there's not, this idea that children could be small but healthy is really very outdated. So that every child has the potential to grow within a normal distribution. And that's what the WHO recently came out with their recommendations. So yeah, I'd be interested to talk to you about your populations you're working with. Yeah.
I have 2 questions. The first one's that in some of the negative outcomes you saw for adults,
Yeah.
was there a differential effect with gender?
Yes. So first to note, great question. I didn't talk about that on the slides, but I did show on the slide that some of them were the red asterisks and some were black. So first of all, our sample of women was about 70% women, 75% women, because they were more often home. So that was, again, the other thing I should have mentioned is the sample has a limitation, which is that it's parents of 2 to 5-year-olds or 8 to 10-year-olds, because those were the adults who we recruited who were recruited because their children were part of the study. But that's why also the sample of women was greater. And I think the sample of women might be more representative because the men who happen to be home might be a slightly skewed sample of men who aren't working. So we found stronger effects across the board among women, is the answer to your question. Some of the effects, I think most of the effects were significant for sexes combined, but in some cases the effects were women only. But we didn't find any where it was just men.
Can I answer like just a conceptual question?
Yeah.
Going back to the whole nutrition transition theory,
Yes.
does it still hold in that kind of clear linear format that you're going to necessarily go through perfect nutrition?
No. Oh my gosh, not at all. That's a great question. I should have, yeah. No, that's true. A middle, like the zone of and now we're perfectly nourished, and that phase lasted for 20 seconds. No, I think that absolutely true, that there are countries that are catapulting across that middle section and just jumping right to being obese. There's examples like South Africa is a great example of that kind of country that's really literally within one generation going from a high prevalence of very high prevalence of undernutrition right over to having a high prevalence of.
There's such potential because people are talking about that, it's overnutrition, or too many calories and
Right, and I didn't even mention the fact that there's a biological underpinning to all of this. A completely plausible explanation, which is that if you're malnourished in utero, for example, if you're low birth weight, then you're biologically programmed to put on more weight more rapidly because the fetus is saying, hey, we got to hold on to every calorie, we're low birth weight, and so then that fetus is vulnerable, differentially vulnerable out in the world. So this is why it's particularly detrimental if you're in that first generation out where all of a sudden you have access to all these calories that you're packing onto a fetus that has the biological vulnerability in addition to the kind of societal availability of all those calories. Great question, thanks. Yeah.
I know that the research is limited, but if you can just speak a little more in colloquial terms or, about undernutrition or malnutrition and obesity happening in the same household or in the same community.
Mm-hmm.
What are the, do you have any recommendations how to avoid that? What are the important questions?
Oh, I just...
You mentioned that stunting happens mostly in the first 2
yeah.
years.
Mm-hmm.
And is...
My best explanation. I see that kind of thing. Whether you might be protected. You mean if you're yes, stunting happens in the first couple. My best explanation for what's happening is that stunting happens in the first couple years, and that you could have the same risk factors that are affecting stunting. For example, low quality nutrients. So you could have enough. You could even potentially have enough calories in the household, but you're not having enough calcium or zinc to grow appropriately. So then those are setting you on a low growth trajectory. And then by the time you're really starting to gain weight, you're fixed in kind of a shorter stature. And then you're gaining weight onto that, you're adding weight onto that smaller frame. And then you're more and more exposed to abundant calories. You're more likely to be drinking soda rather than breast milk. It's possible that you're more protected in those early years because your parents are more responsible for what you're eating, and then in the later years you're going out and you're then consuming more soda on your own. I'm thinking of the study by my colleague Chris Madsen, she did this study in the US where she had children adolescents walking to school, and she did this whole walking to school intervention as a way to reduce obesity, and found that actually walking to school increased obesity because kids were walking to school and buying snacks on the way and buying soda. And I'm thinking that it just goes to show you that when later in your life, as kids become teenagers and have access to their own money, that they're able to then have purchasing power. So then if you're stuck with this small frame and this kind of undernourished frame in terms of your bone structure, that you're not going to have that linear growth, then you're exposed to all of these excess calories, you're consuming more calories, and then have a higher risk for obesity. Yeah.
I work in water, and so I'm
okay. Great.
And so do you see an effect on this duality of and obesity? I mean, is it
interesting?
There's often diarrhea. I'm speculating.
Yeah.
But there's often diarrhea. Like if you're going to eat, sink only a couple of times a month, and then it matches that you had diarrhea at that time, but you're also drinking soda every day.
It's really interesting. No, I haven't. That's a great.
Effect on diarrhea.
Yeah. So what do we know about the effects what association between diarrhea and obesity? Is there? I haven't seen that at all. Okay. Yeah. I don't know. I'd love to think about that further to say what kind of role infectious disease would have in all of this. Or, yeah. I don't know. I have to think about that more. I'm sorry, I don't have more to say about it.
Well, no, I'm now thinking maybe where the sugars absorbed where they absorb earlier, like in the stomach and all of that.
Oh, I think they're absorbed all the way through. Yeah. Oh, whether they're absorbed.
If sugars are absorbed faster than diarrhea, you might be absorbing sugars and you might not be absorbing other micronutrients.
Right. I mean, so much of so I don't know about how this relates to obesity, but I do know that so much of what we're learning about malnutrition and about stunting and wasting and underweight is that there's this huge component, and I'm sure you know all about this, of what's going on in the microbiome that's determining whether or not food is getting absorbed. So you could actually have a totally adequate diet and also be malnourished because of what your microbiota look. Yeah, so that is an area which is so interesting. That was this, I'm sure you've seen this study where looking at identical twins, one of whom was severely malnourished and one of whom wasn't, and they were in the same household and you expect them to have the same level of poor nutrition, and it had all to do with what was going on in their microbiome. So yeah, that's an area that's like open for investigation. It's super interesting. And I should take a look at what's been done about that microbiome and obesity because I really have no idea. That would be interesting.
We have time for one more question. I don't know if anyone
I have a question, actually. Sorry.
Yeah.
You mentioned levels of salivary cortisol.
Yes.
Is that only?
Would you like to talk about saliva?
Is that only among children?
Yes.
Or is that also for the mothers?
That we did not look at the effect of the program on the mother's saliva, but we did look at the effect on the kids. And it was a modified effect. So it was the kids of the moms with high depressive symptoms that showed the biggest effects of the program. So it had something to do with being either more vulnerable or more just open to environmental effects because they had a depressed mom. So we found that connection with the saliva, salivary cortisol. But that was the beginning and the end of my foray into collecting thousands and thousands of swabs of saliva. That study was the first and the last. People approach me and say, do you want to collect? I'm like, no. If you say the word saliva, no more saliva. So it took about 6 years to get those samples assayed. Yeah. And then to try and figure out what the heck it means when you collect 3 samples in the middle of rural Mexico when you have people collecting 12 samples in one day in a lab situation. Yeah, so.
Less disgusting environment.
Yeah. I'm not the one collecting fecal samples, so that to me, right, that could be. Anyways, well, thank you. Sorry to end on that. Thank you all for being such an engaged audience. I appreciate it.